Welcome to CareSmarts 360 on Air, a home care podcast. I'm Erin Cal, account executive at CareSmarts. Today, we've got a guest who's part compliance guru, part quality care virtuoso, and 100% powerhouse, Annette Lee.
Erin.
Annette is the founder of Provider Insights Incorporated, where she's been transforming home health and hospice agencies into champions of excellence. She's a walking encyclopedia on everything from regulations to real world strategies, but don't let that intimidate you. She's here to make it all refreshingly relatable. In this episode, we're looking ahead to 2025 and tackling the home health value-based purchasing, HHVBP model. If HHVBP sounds like alphabet soup, don't worry, Annette will decode it faster than you can say revenue cycle management. Get ready for tips, insights, and maybe a laugh or two as she breaks down what agencies need to know to thrive in the quality-focused future. So grab your headphones and let's chart the course with Annette Lee. Welcome to the podcast, Annette.
Thank you so much, Erin. I have never had an introduction quite like that before. I don't know if I can live up to it, but I will do my best. And I love what you're doing for your agencies and for the community as a whole, being able to share this information. So thanks so much, Erin, and to CareSmarts.
Thank you so much. We really appreciate you being here. We'll jump right into it. What are some proven strategies agencies can adopt to consistently deliver high quality care and score well under the HHVBP framework?
All right. Well, we are in performance year 3. So this is, I can't believe it, but already in the 3rd national year. I live in Iowa, where we were one of the 9 states that also did the pilot for 5 years. So it feels like I've been doing this a long time. The best strategies that we see consistently over and over are education, 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 and then always with verification, making sure that what we're talking about is sticking, it's important, it's always top of mind, and having those key performance indicators for our entire team so we can see that, yes, this really did work. So for instance, knowing that value-based purchasing looks at both your OASIS data and claims data and your patient satisfaction scores through CAHPS, we can kind of break those down into where your biggest pain points are, never taking our eyes off the rest of them, but really trying to focus on those. So for instance, the OASIS measures, making sure that the entire team that would touch an OASIS has a good understanding, not only of the OASIS items themselves, but the measures, because sometimes you think that you're scoring in a way that's going to be positive, and it might not always give you what you think is going to be a thumbs up from the government. So making sure they know what that improvement really looks like and being able to give them that individual feedback, because otherwise we don't really know where we're falling short. So education first. Second of all, know our own pain points. Where do we need to focus? And third, that I think is really quite fun, is making sure that the entire agency is in on this. Every team member, not just the folks who touch the OASIS, but our goals all over with the value-based purchasing, because even the person who picks up the phone when you call the agency has an impact on things. If their response to a patient or family member calling was, well, just head to the ER, that hits our quality measures. Or if we drop the ball and don't follow up and don't call back like we were supposed to, that's going to hit our quality measures, not only for satisfaction and experience, but also perhaps the hospitalization measure, perhaps the new discharge measure. So those are my 3 favorite things: the education, the individual verification, and then finally getting everybody involved and getting some excitement around that we really can make an impact, not only to our scores, but to our patients.
That's great. And with the shift towards value-based care, how should agencies train their caregivers and staff to align with HHVBP objectives and enhance care outcomes?
Yeah, so again, kind of starting out with, where do these measures come from? How do we really know that we're doing the things that we're supposed to? So for instance, the new potentially preventable hospitalization measure, for a million years, we've always known that it is your Medicare population that hit the hospital stay within 60 days. That was our normal routine acute care hospitalization measure. But now, since it's looking at both the acute stay and observation. That's huge. And also ensuring that everyone, again, is part of the solution. Everyone is part of this process. We want the entire team to come together and really talk about when we see rehospitalizations, was there an opportunity? Did we drop the ball? Again, starting from the person who answers the phone, to the case managers, to the LPNs and LVNs, to the home health aide, making sure that we're talking as a team and really focused on those specific measures that impact both our outcomes and the whole patient experience.
Absolutely. And one of the cornerstones of HHVBP, of course, is performance metrics. Can you walk us through the most
Yes.
critical ones agencies need to focus on and how to measure them
Mm.
effectively?
Absolutely. So I think that right now, our kind of the biggest ones are weighted heavier, but also they're the newest. And so keeping these topics in mind when you're planning education is going to be a key for the beginning of this year to start this out right. Because as of January 1st, we have some major changes in the measures that are playing in value-based purchasing for us. So for instance, the new PPH that I just mentioned, the potentially preventable hospitalization. I want some focus there. It is 26+% of our entire weighted score. And that's if you do caps. It's even heavier if you are small enough that you're not doing caps. So it's huge. And the new discharge to community claims-based measure is also large. And it's tracking, did your patients end up back at the hospital within 31 days after you discharged? So the weight of them, and again, understanding the newness that these are the ones that we need to give a little additional focus to. That sort of strategy is huge because again, it hits multiple points on these claims-based measures about the overall care that we provide, because it's looking at, are we giving them enough service, enough tools, enough education, enough support that they're calling us and that they are relying on us whenever possible to avoid that hospitalization. And we are their partners in that, even after discharge. So strategies about looking at maybe making post-discharge phone calls to patients, having them scripted, ensuring that it gets a clinical component if there's a need for one, if there's been things like, have you been to the doctor recently? Were there any medication changes? How are you doing? Are you feeling okay? Any symptom changes? And so those are the things that I want handed off to a nurse to be able to call. And if needed, we'll call back to doc and get them back on service to avoid a rehospitalization even after discharge. The other one that is very weighty is another new one called the discharge function score. That one is coming from the Oasis. And this is the one that you're hearing all the hubbub about. The focus is finally on the GGs. And it's not just the GGs, although that is the primary focus, looking at where did the patient end up in those GG functional measures at discharge, but it's also having to compare, what did these GGs look like for your patient versus the universe? What did they expect? But they have to ensure that this is based on patients that look similar. So there's a multitude of other OASIS items that go into this that give you that risk adjustment that help them project what did they expect. So they're looking at things like caregiver status. They're looking at comorbidities. They're looking at the prior GGs. They're looking at, oh gosh, there's a whole litany, ensuring that they're projecting the expectation correctly for you. So gone are the days where you could just take a glance and say, oh, well, I moved from a 2 to a 1 by discharge, so I know it's appropriate. I know I've got a good measure. That is not what the discharge function score does. I would have to know the whole universe. And so therefore, this is an area where I need accuracy in my GGs and accuracy in the whole oasis. That is a huge shift for us. So I would say those three are our top metrics that we're really honing in on right now.
That's really helpful. Thank you. What role do you see AI and technology playing in helping home care agencies adapt to HHVBP, particularly in areas like outcome tracking and quality improvement?
Hmm. I was surprised how much AI was the hottest topic in town during the national conferences this last year. That's for sure. Everyone is thinking about it, and everyone has, excitement and a little bit of concern and hesitation at the same time. But when it comes to those things you mentioned, Erin, like looking at your QAPI, performance improvement, looking at specific measures, I think it's excellent. I think it will help us predict risk. I think it's one of those things that can really show us this is the type of patient that ends up back at the hospital. So therefore, this is the patient I need to do something more with. I need to care plan appropriately. But also, I really need to ensure that this is also, top of mind if we have the opportunity to utilize it to pull the data from our EMR. Look at the trends, look at the falls, look at the infections, but bigger picture, focusing in on our value-based purchasing measures as well. I think I think we're on the cusp of something huge with it, that's for sure.
Yeah. How do compliance requirements specific to Iowa's home health agencies align with or differ from the national HHVBP framework? And what pitfalls should agencies in the state avoid?
Hmm. So Iowa is lucky. We don't have any additional regulatory requirements in Iowa versus the federal. So that is a great thing. So when we're surveyed, even by our state, it's just looking at those federal COPs. So that's nice. But there are still additional barriers in Iowa and in other states similar to Iowa where we have a high percentage of dually eligible patients, meaning many of our patients in home health have Medicare, but they also qualify for Medicaid, meaning they have that social determinant of health of poverty. They met the level in which they qualify for Medicaid. There's other barriers happening when you're looking at transportation and food insecurity and, maybe health literacy. There's a number of things that home health agencies in our state are trying to bridge the gap. One thing we can do is monitor our health equity reports in IPs. CMS provided us that last fall. And one of those measures looks at, are there differences in outcomes from your Medicare population versus your dual eligible population? So you'll be able to see if you're able to fill the gap and if you're hitting the mark with those patients as well.
And looking ahead to 2025, what key trends or shifts do you predict for the home health value-based purchasing model, and how should agencies prepare for them?
Well, I think the big shift, obviously the new measures, but I think it's also difficult knowing that this is all on a bell curve, right? This is all based on how we look compared to the rest of the nation. So for instance, working with clients, we'd be like, okay, if you can get to 21, you'll be meeting that median mark. You'll be above the fold. And then the next quarter's report would come out and they would be at 21, they would hit their goal, and the rest of the nation moved to the right as well. So unfortunately, it is a moving target. And I expect to see a lot more of that in 25 as we're all pressing to try to ensure that we're not going to be penalized through value-based purchasing, but instead striving for the performance reward. So that I think is a big piece of it, is knowing that everybody is improving. So what we did 2 years ago when this all started did not get you the same measure as what you got the year before when you start getting all of your reports for last year. So 23 cannot be what we did in 24. What we did in 24 can't be what we do in 25. So again, we have to be more innovative. We have to ensure that we are, again, bringing the entire team with us and ensuring that there is, again, that whole culture of excitement about what can we do. I did have some agencies who decided to really ensure that they were looking at individual nurses scores and individual case manager scores. And they actually rewarded them when we had positive growth in the value-based purchasing measures, when it was partly due to their outcomes and their scores. So they were highly motivated then when they knew there was really something on the line for themselves as well as the patients and the agency. So that worked well. That was something that I was pleased that people all got on board and got excited about it.
Oh, that's great. Yeah. Well,
Mhm.
thank you so much, Annette, for sharing your expertise. Really appreciate having you here. And to our lovely audience, thank you for tuning in. I'm Erin Cal for Care Smarts, signing off.
Thank you, Erin.